Welcome to our final session today. We have a privilege of hearing from all our presenters as they review some compelling, minimally invasive surgery case studies. Dr. Simon will be our moderator for today. So I will just hand it over to Dr. Simon to get us started.
Okay. Great. So navigating complex cases. This is our panel, Dr. Bourgeois, Chen, and Dr. Patra. We've all been introduced to. There's some tough calls. We have the data which suggests this is a useful technology and a useful strategy in helping certain patients, but that leaves a lot of questions. One would be basal ganglia ICH, and there would be patients who are outside the trial criteria in some other way. The role for decompressive hemicraniectomy remains unclear. IVH is a separate disease and separate disease process, but a lot of times it's the worst part of what could be a small ICH. There are also unexpected vascular malformations found at surgery. Sometimes they're not unexpected. Sometimes we know they're there, and the question is when to charge ahead or when to take a different strategy. Rebleeding is a reality that everyone hopes to minimize, but no one is going to get rid of. And then there are practical concerns, like you just got a new ICH and the retractors that you just used in the last case are covered with the other patient's ICH. And now what are you going to do? So let's just get to the cases. I'll present the cases and then I'll ask the panelists what they think they would do initially, and then we'll see what actually happened and if anybody changes their mind. This is a 37-year-old who collapsed 1 hour ago. History of cocaine use. CT shows 51 cc ICH. You actually can see a little bit of IVH in the left lateral ventricle if you look there. That would be a sagittal view, but negative for any spot sign or any sort of AVM or anything. And his exam, even in this acute period, is right hemiplegia, left pupil 5 millimeters and minimally reactive, right 3 millimeters and reactive. So Dr. Bourgeois, what are your first thoughts?
I suspect this is it. This is a case of we talked about chronic hypertension leading to intracerebral hemorrhage. This is a case of acute hypertension, presumably from a sympathomimetic drug ingestion. So I'm thinking about early blood pressure control, of course. There's probably not a coagulopathy associated with this. Getting outside of clinical trial evidence, you could use something like a ROTEM to see if there's anything we could supplement medically. But the thing that I'm thinking about is in this young person with a relatively full brain early on, I'm very concerned about mass effect. I'm going to be reaching for osmotherapy early here, and then I'm going to consult my other colleagues to our side here and early engagement of surgical intervention, because I'm concerned that we'll reach the limits of osmotherapy very quickly here and need to consider surgical intervention.
Dr. Chen, your thoughts?
I agree with all of that. I think that we would get our neurocritical care team to optimize the patient quickly, get the blood pressure control, make sure the coag's okay, and then take the patient to the operating room and go to evacuate this by a forehead region approach.
So you guys brought up or at least one interesting thing, and maybe one has gone unsaid. One is the use of hypertonic saline or mannitol. Like oftentimes we use that intracranial pressure to squeeze the hematoma out the hole we're making, and it makes the procedure much easier. But in this case, the patient, I think we can agree, all three of us can concur that he's actively herniating. So do we change how much we give, when we give it?
I think it depends on how quickly you can get to the operating room. So, it's easy enough to say, let's go to the operating room right now. But the truth is you've got to get it set up. You've got to get the nurses opening everything. So it's not quite as quick as we want it to be.
Yeah, hypertonic saline is going to get in if you're using 23.4% over 10 minutes. or over 20 minutes, 30 minutes for 3%, mannitol, similar time frame. And so, you know, those are realistically, I think, a bridging maneuver while you're dealing with the logistics of arranging an operating room. And then the effect of those, the duration of the effect of those is not fully clear in our, you know, in our mind. I think if you're on the operating room table, you probably don't need to do, like you're saying, you may avoid that so-called brain relaxation of an administration of mannitol intraoperatively, but I think probably in the emergency room, while we have evidence of active secondary brain injury accruing, I think it would be still appropriate to use that. But it's an interesting question. If you can get there faster and you feel that there's benefit from the sort of the recoil or the pressure of the brain around the hematoma, perhaps it improves your evacuation.
I can share with the group that if I have a patient who is not so acute, I make a point of asking to avoid hyperosmolar therapy just to make the surgery a little bit quicker and a little bit easier on me. But I agree in this case with impending, if not ongoing, herniation, that is key. The second thing I wanted to bring up is there's relatively robust evidence that it's really hard to control bleeding in the hyperacute period. So the audience might be wondering, well, if we're doing all these stroke trials at less than 6 or less than 8 hours, now we're looking at longer windows, but initially that was when all the data was focused. Why are we not doing that in ICH? Some people are a bit cynical and think it's because, you know, neurosurgeons don't want to have to operate on these people in the middle of the night. I can assure you we're operating in the middle of the night anyway, and this would be no big change. But it's because it's very hard to control the bleeding. And let's just move forward with the case. So I did my approach. I think I used sort of a tough to tell here. I think this is like a Coker's approach, but I also am not afraid to use the forehead just to find a crease or the eyebrow if that's the best approach. The reason I'm showing this bone window first is first to show you that I did it, in case you wondered. And then there is some decompression. Here's this air that got in. If this was totally full, you know, the air wouldn't be able to get in. So we did get some relaxation. But the reason I'm not showing you the brain windows first is that was the post-op scan. So there are two things to consider. One is we didn't do nearly as good a job as we thought. We didn't get down to that 15 milliliter volume. And I don't have an intraoperative ultrasound or photograph to share with you, but you're just going to have to take my word from it. Like the residents always tell the attendings, dude, it was dry when I closed it. And then by the time you got to the CT scanner, which couldn't have been more than 30 minutes, it's protocol just to proceed directly to the CT scanner. All of this is back. So, Doc, so have either of you seen this in your practice with these early evacuations?
This is pretty high up, right? The basal ganglia is probably decompressed.
I don't have good images. I just pulled the one screenshot to show the rebleeding. I can't answer that, but you make a good point.
Right, because I think you get to the epicenter and you decompress the epicenter. Oftentimes you can't get everything out all around, and you don't want to go digging there. And sometimes if there's a bit that remains, oftentimes I'll leave a catheter in there and get the rest out by TPA later on, or an IRAFlow, and wash out the rest later on. But if you decompress it and you've got the basal ganglia decompressed, that's what you're trying to do.
Well, I you know, lack of a better word, kind of freaked out and just did a decompressive hemicranie. So for the uninitiated in the audience, you can see here's the right side of the skull. We look at these as though we're looking from the feet of the patient. Here's the left side, and you can see the skull is missing. And I got the hematoma out. I just used the brain path that I had created and got it out and just left the bone off. And he had a miserable outcome. Hemiplegic and aphasic for the rest of his life.
Do you recall if there was MR imaging showing evidence of herniation-related injury on the brainstem in this case, or do you think this was driven by the basal ganglia and cerebral process that you're illustrating here?
Hard to know. I mean, usually in isolated basal ganglia injury in people less than 40, we see a little recovery.
Agreed. Yeah, agreed.
But when we keep in mind that he was herniating and I got the blood out, but then he was probably herniating again. I mean, I didn't wait to get an exam. I just took him back. You know, it was prolonged. So I think there are many, many ways this person could be knocked down.
Well, I salute the aggressive management, even if the outcome was untoward.
But if you hear your neurosurgeons being like, you know, in a stroke would be like an hour, oh, even better. Like, let's be more aggressive. Whereas if you see somebody be like, let's hold on for a second. Early rebleeding is definitely real. That happens. So let's go to case 2. Sudden onset left weakness. You can see some shift there with a right-sided ICH. Family says it's under control. CTA negative for spot sign. That's the exam, the expected left hemiplegia. No impending herniation syndrome. Oops. Wait. Darn. Okay, sorry. I lost track of my cases. But what's the team's thought here?
Yeah, thanks, Dr. Simon. It seems like it's a relatively young patient, not too old. More like a lobar hemorrhage. There's some edema around it, some midline ship. So the patient had hemiplegia, but do you know if the patient was conscious or
Yes.
more like
awake.
attended?
Awake, but sleepy.
Okay. I mean, seems like probably the NIST score would be at least more than 5 and pretty good midline shape. So I think surgery is very much kind of indicated. I mean, I probably would have considered for like a MIS evacuation. It's the right side, pretty superficial with a direct trajectory with the cannula.
Yeah, I think this is one that we would agree, you know, is kind of a really good case. But this was when the data was emerging, and my partner just elected, since it was so shallow, just elected to do the hemicranie. And when he was giving me this case, you know, he said, now I would have done something different. But 3 years ago, you know, this seemed like a good way to get complete decompression. And I don't know that we can disagree with that. But I think, as we've seen, if you get the clot out quickly, the brain really relaxes, and the hemicranie is not really necessary. So let's skip ahead to something maybe a little more interesting. 38-year-old female with sudden onset left weakness, no history of hypertension, somnolent, pupils equal, left hemiplegia, and she's got this hemorrhage. So Dr. Chen, Dr. Patra gave us his initial thoughts on the last one. Maybe you can do this one.
Yeah, I mean, pretty young patient. And it's kind of a little bit in the basal ganglia and kind of external capsule, some IVH.
So I think we can agree that by definition,
Yeah.
it is outside of enrich, or enrich showed no clear benefit.
Right. Well, I think you know, for the evaluation on this patient, it's not a ton of midline shift, but stroke scale is pretty high. Especially young patients who are at least needed some kind of vascular imaging to make sure there is nothing wrong there in a young patient.
Oh, you're obviously a very experienced operator. You've read my mind here. This is not typical, but this was read as suspicious for moyamoya on CTA. Does that change your thinking at all, or true but unrelated?
Well, I mean, this is not uncommon, although you know, in you know, in American population, we see, you know, not much of a hemorrhage with the moyamoyas, but this is not an uncommon finding with the moyamoyas, having a basal ganglia bleed from those you know, fragile perforators with those you know, hypertrophied perforators. So I think considering all the midline shift and everything, and the patient being weak and somnolent, I think, probably we should consider surgery to kind of at least relieve some of the mass effect. Of course, there is always a risk of rehemorrhage with these patients. But seems like the stroke scale is pretty high and is pretty,
Dr. Bourgeois, what do you think about ICH evacuation more strictly for ICP control versus, improving outcome by decreasing cytotoxicity? So do you insist on an ICP monitor before that was done? Do you think the Moya means that the CPP is a little bit lower and therefore the ICP is more important in this particular patient? What are your thoughts?
Yeah, you're absolutely going to be at risk for deep territory ischemia. Well, it's hard to predict the creation of collateral flow in patients like this. So you would think maybe deep territory globally, you may think perihematomal hypoperfusion, but really the watershed territories are very unpredictable in these kinds of patients. I tend to be I don't demand anything of my surgical colleagues. We work in collaboration, and so I think it would be a conversation about whether pressure monitoring could be helpful in the context of having an exam to follow, meaning a patient who's awake and who I can assess the degree of strength. I think non-invasive monitoring, meaning following neurologic exam, is a reasonable strategy. But this is somebody that I'd be very concerned about decompensating from a pressure perspective. A 38-year-old female without evidence of prior ischemic disease, no encephalomalacia to allow for accommodation of this additional mass effect. I have a very low threshold to think about some form of decompression. Whether or not we pursue evacuation, I think, is going to be challenging. As you mentioned, these friable vessels that you may encounter, that hematoma cavity. Obviously, I'm going to defer to my surgical colleagues here on their thoughts on trying to get into that space surgically, anatomically. But I do think we're going to run into pressure issues eventually, and I would expect within 24 or 48 hours, if not up front, this person to become more sleepy and then to have a less reliable clinical exam to follow purely on the external basis, on the non-invasive basis. So I think you're going to run into needing that, or you're going to be flying blind and run diffuse risk of hypoperfusion to various territories.
So my partner who gave me this case did a decompressive hemicranie, and his thinking, which I think is certainly defensible, it might be controversial, it might be a 50-50 coin flip decision, was that there's no obvious benefit to getting that blood out of the basal ganglia. And what this patient needed was a decrease in ICP. And he thought this was a safe and perfectly acceptable way to do that. And, he was able to achieve it. Dr. Chen, what do you think about hemicranie versus MIS for basal ganglia hemorrhage?
I would do two things. I would put a ventriculostomy in, so you get your ICP and you can help control your edema and increase ICP. But also, I would consider going in with MIS again via a forehead type approach. I think you can get in there and you can decompress a good amount of that also. So I think that's something to consider. But again, this worked. I think decompression worked, and over time that blood clot will go away. The whole issue of the Moya, I think clouds things a bit. I think if it wasn't for that, I think without a doubt, I would consider going with the MIS approach.
What is your experience looking at these hematoma cavities in folks with these? I mean, the anatomically going to be somewhat distinct from a typical lateral lenticulostriate perforators. Do you observe that macroscopically?
I can't say I've ever operated anybody with Moya with a basal ganglia hemorrhage. I have not had that experience.
I think part of the goal of hematoma evacuation in this patient is just to partially evacuate the hematoma, not trying to kind of take out every little bit of clot, especially whatever is coming out with suction nicely without especially just kind of avoiding the walls is important to kind of getting into those fragile perforators. And in these patients, like, I think my preference would be to avoid any kind of a bigger craniectomy, just because they might need some form of revascularization in the future. And that way we can preserve as much anatomy for a future revascularization as needed. Of course, if a patient with, if patient is kind of deteriorating and kind of becoming more and more, less responsive, and there's a lot of ICP issue, then hemicraniectomy is something, kind of last resort.
I think you bring up a
I
great
see
point
what-
about saving the STA for a bypass in the future.
Yeah,
But we just have a few minutes left. I want to get in this case. This was actually already presented in operative neurosurgery, but I thought it was very interesting. Also from our institution, 51-year-old found down history of moyamoya, left direct bypass, then lost to follow-up, comes in with this hemorrhage in a weird place. Your faces are blocking it up for me, so that's why I'm playing around with the mouse, but sort of certainly interventricular all over the place, which causes its own problems. But then there's like a little something in here, intubated, actually purposeful bilaterally. The patient was taken an angiogram because it was such an odd looking hemorrhage, and they found a lenticulostriate aneurysm. So you've got an IVH with an ICH and an aneurysm that is very tough to treat endovascularly, but we have every suspicion is actually hemorrhaged. So what is, now this has been published. If you've read the study, I ask you to play dumb, but what does the group think about all of these concomitant problems or overlapping problems? Nothing?
I think this is a case where I'm rapidly going to run out of tools to use that'll be helpful to you.
Interesting. Do you think an earflow would be helpful here?
Oh yeah, if you can
Airflow
get
would
an
be very helpful.
an airflow in there, would be extremely helpful. Yeah.
So that is something that IVH itself was not addressed in the ENRICH trial for very good reason, but that I don't think it contraindicates or includes a patient. You just we have different ways of looking at it. There was the CLEAR trial, which did not necessarily decrease shunt dependency, and there's an IVH trial going on now with the IRRAflow, but certainly in the critical care community and in our practice, that has really taken off. So I think that's reasonable for that. I think this ICH doesn't really require evacuation, especially if you have control of this. But with regard to this, the team actually put in a retractor using, of course, femoral stereotaxy, and that's the aneurysm. And they just, you can see this is the bipolar, and they actually just resected it and buzzed around, and that was enough. And there's pre-angiogram, post-angiogram. So the reason I brought this up, or I thought it was interesting, was, in ENRICH, they excluded those people with lesions that were associated with the ICH, like aneurysms or AVMs. And it made sense to exclude that because we were trying to evaluate the effect on treating the hematoma. And people who have a subarachnoid hemorrhage, ICH/SAH, or have AVMs, the natural history of those lesions is very different and very complicated and would muddy the result of the study. But that does not mean that you can't use this for aneurysms or AVMs. It's a perfectly reasonable arrow in your quiver as a surgeon. So I'm afraid we're out of time. Do you guys have a final statement you want to make or a send-off?
that was a really a great case to show. The authors should be commended for their excellent outcome. But sometimes these things can be scary. If there is like an intraventricular approaching and there is a intraoperative rupture, and things can go south, and it's just very hard to control with that tubular retractor. And so having some kind of backup plan is always is a necessary. But they got it. I mean, this is great.
Dr. Chen, you have your microphone on.
Yeah, there's a lot you can do with the tubular retractor. I think you'll be surprised at how much you can really see, either with a microscope or exoscope, and the ability to use two hands, with bipolar in one hand and something else in the other hand, you can do quite a bit.
Dr. Bourgeois?
I just want to say I'm grateful, as a neurointensivist, I'm really grateful to have neurosurgeons who are highly invested in the management of our intracerebral hemorrhage patients. And I think our every day is a school day for me, learning from you in terms of interventions and things we can do. And I'm grateful for the advances we have here, because I think these are going to define a new era of intracerebral hemorrhage care across the board for us.
All right. Well, I want to thank each of our participants as well as the AHA for hosting this event. And Susan, I'll kick it back to you.
Thank you all. I will send us off. I just want to thank all of our distinguished speakers today for sharing your time and expertise on ICH, minimally invasive surgery, and to all the attendees for your participation. Following today's webinar, you'll receive a post-event survey, and your feedback's very valuable to us to guide development for future educational opportunities. Again, this program was presented as part of our hemorrhagic stroke quality improvement initiative supported by Stryker. So on behalf of the American Heart Association and our presenters, we appreciate your engagement and wish you a pleasant rest of your day. Thank you, everyone. Take care.